Hi everyone, and welcome to ABC's of Anesthesia. And here we are for our second installment of the 2024 exam paper, the second paper of 2024. I'm here with Vida. Vida, how's it going?
Hi, good. I'm well. Thank you very much for doing this. I think it's a very useful refresher for candidates.
Again, so good to have you, Biz. You're an ex-chair of examiners. You did 12 years of examining. So if anyone knows about the final exam, you're the person who knows. And I every time I say an opinion, I feel like a lot of it's probably come from chatting to you and other examiners, but it's far better to get it straight from you.
Well, I was an examiner a while ago, but I do keep up with other examiners, not that they're able to impart any information from the cone of silence, the important elements of keeping the sanctity of the exam. But I have done every exam since about 2000, and I do keep up with elements of the exam, and I find it very informative. The exam reports prepared by the examiners has changed a great deal since my time. They are a wonderful, wonderful resource, and as we said before, I urge all people who are involved in candidate exam preparation and candidates themselves to study those exam reports carefully.
Fantastic. So we're going to go through the first Viva from the 2024 second sitting paper. And we'll do it like the last format, where I'll pretty much go through the slides, ask you questions, and you'll give us your answers and certain thoughts as we pause and discuss through the Viva. So let's get started. So this is a case of a mitral valve disease in a 10-year-old dental procedure. The pass rate is 71%. And here we have the stem. And like always, I think we say, read lots of detail here, but read the question first, because that frames everything. In your preoperative review of this patient with her mother, what information on history and examination will you seek? Actually, just for everyone listening, I will speak. I'll speak through the Viva stem. A 10-year-old girl has been added to your dental list today at a tertiary hospital. She is scheduled for dental extractions and treatment under general anesthesia. Her medical history is rheumatic mitral valvular disease. Medications include furosemide, 30 milligrams BD, spironolactone, 25 milligrams once daily, and allergies, none nor nil known. Observations on admission: height is 150 centimeters, weight 35 kilograms, BMI 15, heart rate 117, blood pressure 95/60, SATs 96% on room air. And again, the question: in your preoperative review of this patient with her mother, what information on history and examination will you seek? So everyone who's listening or watching can pause it and take the 2 minutes, write notes. But you're happy to crack on.
Yes, this question is the one for which candidates have 2 minutes, so it is important to write some thoughts down. And as I urge candidates to do, have a simple construct. And mine here was for history and examination: routine and specific. Routine antenatal history, the medications that are noted, allergies, and milestones achieved for this child. It is noteworthy that her BMI is 15 and that she's on some anti-failure medication. Specific to her mitral valve disease is relatively rare in pediatrics, but mitral rheumatic disease is more common than aortic rheumatic disease. You want to know about duration of disease, and presuming the patient has recovered from the acute episode that caused her mitral valve damage and its consequences, you presume that the patient's unoperated and that the dental surgery is in anticipation of the surgery. It's not necessarily true, but it's a reasonable assumption to make. Determining where the patient is on the continuum of compensated disease, transitional disease, or decompensated mitral valvular disease is important. She clearly does have a history of failure, and you want to know about the effectiveness of the diuretics that she's taking. That's available on history and examination. You want to know about a history of pulmonary hypertension. That's not usually evident on exam to any significant degree, but you'll ask about investigations later. And the treatment of acute AF promptly. Reverse the reversible plus or minus cardioversion. Why did I include that? You might have to cut this out. Why did I include that? Yeah, treatment.
As in, it's probably the significance if they've had AF, because it's common in mitral valve disease.
Yeah, maybe.
You mentioned, but yeah.
Yeah, I'm just not quite sure why I included it there. And with respect to exam, the pansystolic murmur and mitral regurgitation at the apex, seen initially in the harsh diastolic murmur of mitral stenosis, may develop over time. It's a good signal to the examiner that you anticipate this development in
this is
prognosis of disease.
As far as I can see, this is like the severity stability framework. A lot of the things.
Correct.
And when obviously in the exam, you'll get this stem, and you've done this thing where you've gone, oh, look, they don't mention failure, but they're on treatment that would assume the patient has been treated for failure. So you're taking information, you're not just repeating it, you're synthesizing it into something that means important, facts for the patient.
And it's important to use the phrase, in this patient, it reminds yourself that you're thinking of this scenario, not just a general scenario, and it signals to the examiner that that's what you're thinking.
And so sometimes on history examination, obviously, you're not looking at what investigations would you have, but the question I asked you previously was, do you think it's worthwhile saying, look, when I review specialist notes, I'll be looking for investigations on the past, which is part of the history? Is that a technicality in how we should present this, or do you think not it's okay?
Yeah, candidates need not get hung up on that. This is just an easy way to break down the seeking of information. History and exam, and if you say you'll seek investigations, the examiner might say, oh, we'll get on to investigations in a moment, if they don't want you to go down that path of investigations as something that characterises the severity and stability of the disease. It's no biggie. Whether you do or you do not, I don't think candidates should get hung up on that. The examiner will guide you.
Amazing. Next question. What are the implications of rheumatic valvular disease in a child for general anesthesia?
This is not intended to destabilise candidates. We're used to dealing with adults with valvular heart disease unless a candidate has done a specialist paediatric term with the subspecialty of cardiac disease. They will be unfamiliar with the presentation of this disease in paediatrics. It's very, very important to note that the pass rate for this fibre was 70%, so that you can, as a doctor, translate all of those things that you know about mitral valvular disease in the adult to the paediatric setting. So we know that rheumatic valvular disease causes permanent valvular damage, and here there is mitral regurgitation, we are told. The complications of that circumstance is that there is the possibility for failure, as in this patient, pulmonary hypertension, infective endocarditis, pulmonary emboli, and dysrhythmias. Candidate may or may not know that the prognosis is worse in females, and that the treatment is with afterload reducing drugs, as here, and the treatment of failure. The hemodynamic goals in general anaesthesia in paediatrics is to, just as with mitral valvular disease, mitral regurgitation in adults, to optimise forward flow and minimise the regurgitant volume. Optimising preload, having a normal to high heart rate that's in sinus rhythm, reducing afterload, maintaining contractility, and the use of antibiotics for endocarditis are all the principles in adult cardiac disease that also translate to paediatric surgery. And it's important to check for failure with the investigations of a chest X-ray, ECG, TOE, and consultation, as you said.
I like what you said there, that this is, it is a specialist thing to be looking after kids with.
Very much so.
But you can absolutely talk about this in good general terms. I think everyone can look at this and go, yeah, I think I know that. And they know it from adult practice, but to panic and think, speak really without confidence and, second guess themselves would be the worst thing. So maybe, what you said, acknowledge to yourself, look, I haven't done much pediatrics in, heart disease pediatric cases, but these are the principles. That I feel like that's a good way of just giving yourself a bit of a out, or not claiming you're a specialist.
Very much so. This is not the final exam in pediatric cardiology, cardiological anesthesia. That is not what we're doing here. It's the examination of the ability of a candidate to translate what they know from first principles in physiology to the pediatric setting. And then, of course, if you or I don't know if you're a pediatric cardiac anaesthetist, I'm not. I've done plenty of adult cardiac, but I would seek information from a colleague who's done pediatric cardiac surgery. Yes. So that's the important thing. And just as parents don't want us to to say to them, I've got no idea about this question, so do examiners. And it's important for candidates to put into context the abundance of knowledge that they have and to slot that in, but of course to consult specialists in the subspecialty field should that be necessary. One of the other things that I thought about since we were moving on to investigations was for the possibility of an ECG for a pediatric patient. I personally have not seen many ECGs for pediatric patients. And again, this is an opportunity for the candidates to say, from first principles, I presume the beating heart is the same in a pediatric patient and the general principles apply. The reason you would ask for an ECG in a pediatric patient is the same as for an adult. You would assess chamber hypertrophy and strain, and to acknowledge that maybe, just maybe, in a child, the ECG is more complex and must take into account the child's age and comparison of normal values at all those different ages and for specialist consultation. But you shouldn't run screaming out of the room just because you're presented with something that is out of the ordinary. Apply first principles and then seek better knowledge from an expert.
Yeah, that makes a lot of sense. Some information here.
So this is information that I just included for the general mitral valvular disease, just as a refresher for candidates. You won't get this patient in the next exam, but it's just a reminder for these pressure volume loops and that are useful for candidates to remember.
Yeah, excellent. And mitral regurg, again, these are just your grades of severity.
Correct.
And everyone can just have a look at that in their own time. It would be too hard to go into it. So if you're listening to the podcast, just have a look at the YouTube video. You'll be able to see these graphs. But essentially, you've got some guidelines here. Maintain forward flow, minimize regurg to volume. Yep, we've already talked about that. Reduce half flow, maintain preload contractility. And this lovely table that you'll see from a lot of the critical inductions presentations on YouTube as well. But yeah, the different goals, preload, afterload, heart rate, contractility goals with each of your lesions.
And certainly before each cardiac case that I used to do, I used to rehearse and my goals with respect to preload, SVR, heart rate and contractility. It's just an important thing to have in mind. And of course, it creates a very elegant and structured answer for how will you give this anaesthetic. You will address issues, have goals in mind, and how to achieve them.
Perfect. Section 1, so this is all information from the examiner's report, and we'll go through now, so demonstrating understanding of the implication of valvular disease in child and formulating a safe anesthesia plan. So that's what we've done. Who said this was urgent?
Yeah, it's interesting. If you look at the STEM, for this is a patient scheduled for dental extractions. And then in the exam report, it says there is a comment that this surgery is for urgent dental surgery, which is interesting. It's not in the STEM that this is urgent, which would create a different timeline and a time pressure for candidates with respect to stabilisation of the patient, seeking extra investigations. So that was just a little anomaly. Not criticising the exam reports at all. In fact, I have nothing but great praise for how much information and how much guidance is in these exam reports. They are gold mines for exam preparation.
Absolutely. So maybe a little typo.
And again, it's nothing to get hung up about, but it is something for candidates to think about. How is this changed if the surgery is urgent? Is my timeline a matter of hours or is it a matter of a week so that I can do any failure management, any consultation that I like, or if I have a limited amount of time? That changes things, and I think that's an important exercise for candidates to go through.
Excellent. Next question is, how will you anaesthetize her?
And again, anaesthesia involves the identification of issues and their management. And I have inserted those into a pre-op, intra-op and post-op scheme. So how will I how will I prepare her pre-operatively? I would use history examination and investigation and consultations to ensure the treatment of failure and the anticipated issues of dysrhythmias and failure. There's routine and specific history, fast, give usual morning meds with a sip of water. Intraoperatively, I would have this as the first case. I would use escalated monitoring, intraarterial blood pressure, in addition to usual monitors, plus or minus a nasal tube so that I can keep out of the way of the shared airway dental procedure and the hemodynamic goals as have been stated. I would use these drugs in these doses for a 35 kilo patient. Again, it's very important to quickly state what drugs you will use, what route you will give them in, and the doses, as I said, for a 35 kilo patient. Milligrams per kilograms is most easy. And post-operatively, it's unclear to me whether this is a day procedure. It's probably best to do this in a facility where the anticipated complications can be managed. So whether or not that was part of the Viva, I'm not sure, but I think this patient should stay overnight just for observations of anticipated complications.
And what would be your induction plan for this patient in terms of drugs and doses?
I haven't got those to hand, but just this patient with managed failure can certainly have a total intravenous anaesthetic with a muscle relaxant and a nasal tube in the routine milligram per kilogram doses with a CP of 3 to 4. Yeah,
and I was thinking, if I'm ever going to reach for an inotrope or vasopressor, it would be ephedrine for these patients. Absolutely. It's to hand, and it's you don't expect that this is a patient with decompensated mitral regurgitation. This is in anticipation, I believe, of surgery. Yeah. Excellent. All is going well until this happens on your monitor. What will you do?
It's important for a candidate to say, as anticipated, we thought there may be some dysrhythmia. This is rapid SVT, as characterised by a regular narrow complex tachycardia that is less than 300, but only just, presumably with hemodynamic compromise, taking over ventilation for this patient with 100% oxygen to keep the patient safe, check all the monitors, especially blood pressure, survey the surgical field and all connections. Communicating with the surgeon is very important, whether or not this is caused by bleeding, unlikely in this setting, or the possibility of an adrenaline-containing solution that the operator may have used. Simultaneously take blood gases to check electrolytes and hemoglobin, and prepare for rate management or cardioversion. There are algorithms. I think I've got a slide coming up with respect to the administration of adenosine as a medical manoeuvre, as a pharmacological manoeuvre, or the administration of a DC shock at 1 to 2 joules per kilo.
Excellent. And here we can see vagal manoeuvre, no, give sedation analgesia, synchronized DC shock 1 joule per kilo. Then after that, if it fails, 2 joules per kilo.
Sure.
And then we've got adenosine here, 100 mics per kilo, max 6 milligrams, increased to 200 mics per kilo, max 12 milligrams after 2 minutes. And then after that, 300 mics per kilo, max 12 milligrams after another 2 minutes. And that's the flowchart from the APLS.
Yeah. And certainly these are not drugs that I'm familiar with giving, but I think all candidates should be familiar with them, and the knowledge that adenosine is a useful rate controlling drug, and not to hesitate to use electrical cardioversion for this.
Yeah, and really, I love that. You're setting up for that, but you can be giving medramynol to prop up the heart, prop up the blood pressure, and
lower the heart rate. Yeah,
and lower the heart rate, and check for reversible causes, because maybe the electrolytes are completely off with the furosemide and diuretics that they've been giving.
Sure.
And we've got a table here again. Have a look on the video. Cause of tachyarrhythmias and differentiating clinical features. We won't need to go through that. In PACU, there's post-extubation nasal bleeding and airway compromise. What will you do?
Again, this is for anybody who does a lot of dental work or uses nasopharyngeal airways. There comes a time, it becomes your day when there is catastrophic nasal bleeding. Attending the patient sitting up, reassuring the patient, applying gentle nasal pressure and the administration of oxygen with a bag and mask. It's obviously tricky feng shui in this situation where the patient's bleeding from the nose and perhaps is struggling to breathe. Administering Otrivin or some sort of nasal decongestant, some sort of sympathetic stimulant in a soaked gauze intranasally is what I usually do, and prepared to intubate with an oral tube using, again, propofol, succinylmethonium, and managing hemodynamics as before. Preparing to deeply suction the airway with a wire suction to remove the clot. If that's the problem with airway exchange, usually clots break up and don't cause complete obstruction of the airway, but it's very important to communicate reassurance that everything's being done to control the situation. And managing the nasal bleed. So those are the safety features that you could do to immediately address the situation with respect to the nasal gauze and the suction and reassurance. And then managing the nasal bleed. The next escalation of steps include a Foley catheter along the floor of the nose to stem bleeding if the bleeding is in the posterior part of the nose, and anticipating a return to theatre and consulting an ENT surgeon for possible cautery. Resuscitate as required with blood or blood products. Over a very short period of time, this bleeding can be significant. Make sure nowhere else is bleeding. Make sure there's no cause in the mouth, for example, from the surgery that has been a cause of bleeding in this patient, and managing of the complications, aspiration, atelectasis and impaired VQ, and possibly a bronchoscopic removal of clot for this patient. In a in a Google search that I did for this case, I saw, and if you could show the next slide, there is a intellectually impaired young person who had this complication, who was treated with a Foley catheter in recovery, obviously done under some small degree of sedation successfully, which I thought was very impressive. I've had nasal bleeds, not very many, thankfully, in my life, but they are very difficult to manage. And it is very good management for somebody to have been able to place a Foley catheter along the floor of the mouth, inflate the balloon, not enough to cause discomfort or a further exacerbation of the feeling of dyspnea for the patient. It's very impressive. But that's where the use of cofenolcaine comes in. That not only acts as a vasoconstrictor, but it also facilitates the insertion of a Foley catheter for such a patient.
And yeah, if you want a bit more information on that case study, acute management of massive epistaxis after nasotracheal extubation. So if you Google that, it's an Anesthesia Progress, which is the Journal of Sedation and Anesthesiology in Dentistry. Not the be all and end all, but a useful little.
No, I thought it was a very interesting description of the use of Foley catheter, which certainly I used to use a lot in emergency, but less so in anesthesia practice.
Yeah, absolutely. And so that was section 3, management of post-extubation nasal bleeding with associated airway compromise. So to describe the management of it. And what I noticed about that, if we just go back to this, a lot of candidates, when they start out talking about a crisis, they don't tell a full story. They're waiting for more information, which is reasonable. It's what happens in real life. But for you to be able to say, this is the full story of what I reasonably assume is going to happen in this crisis in roughly a worst case scenario, you're just going to keep talking through the whole story. And if the examiners say, oh, actually, the first pinching of the nose sorted it, great. Then
right.
You stop. But you're ready to give a full story because you've done this before, you've imagined this before, and you can see it in real time. You're not just stopping at suctioning the airway. You're not just stopping at a Foley catheter. You're preparing stuff. You're getting things ready for the worst case scenario, which is part of the CRM, anticipate and plan thing, and then managing complications. Again, anticipating, planning, really important things without having to be prompted.
And I don't know how this Viva evolved, but in my mind, this was a very good exercise for the learning point of the examiner asks the questions, not the candidate. So it's often tempting for the candidate, particularly for candidates who have a lot of experience, to say, well, what's going on? I need to have more information. This is a matter of examination technique where you say, if something simple like the application of a an Otriven soaked gauze and the pinching of the nose and sitting up and reassurance manages the problem, that's great. I will be preparing for an ENT consult return to theatre for cautery. I will be examining the mouth for further bleeding. And if, as the initial question said, there is a difficulty with air exchange, I'll be preparing for reintubation orally of this patient so that the problem can be managed in an alternate way.
Excellent. So I think, that's the end of that Viva. So that's Viva 1. If anyone has any questions or comments, just please write below in the YouTube comment section. We'll try to get to it. And also there's the Anesthesia Final Exam course. So I'll put this full video up on the Anesthesia Final Exam course as well. And also a plug for the ASA that does great education events.
Well, thank you very much for doing this. I'll put this up on the ASA website for candidates, for trainees as well. So thank you very much.
Amazing. So we'll end it here. Please share with anyone who may be interested, and we'll see you guys again next time.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.